Hello everyone and welcome to Rare à l'écoute, the podcast channel dedicated to rare disease. Today we continue to explore Cushing syndrome, and for this we are pleased to welcome Professor Jérôme Bertherat. Professor Bertherat, good morning.
Good morning.
Professor Bertherat, you are an endocrinologist, a university professor at the Paris Faculty of Medicine, and a hospital practitioner heading the endocrinology department of the Cochin Hospital in Paris. You are also responsible for the Referent Center for Rare Adrenal Diseases and the medical referent of FIRENDO, the Rare Endocrine Disease Network in France. Professor Bertherat, today we are discussing the management of Cushing syndrome. So my first question is quite obvious. What are the main principles regarding the management of patients with Cushing syndrome?
Well, the first principle, as often in medicine, is to treat the cause. So Cushing syndrome is a complex situation because there are various causes. So when the cause, which is the most frequent, in fact, is in the pituitary, the first approach is to remove the pituitary adenoma that caused the Cushing syndrome. When the cause is an adrenal lesion, one of the first approach, if it's feasible, is to remove this adrenal lesion. And when the cause is a neuroendocrine tumor that can be in the lung or in the pancreas, the first approach is also to treat this neuroendocrine tumor. In any case, when it's difficult to treat the cause or when it's not possible immediately to treat it, one major approach is to control cortisol excess, because all the consequences of Cushing syndrome, regardless of the cause, are due to an excessive secretion of cortisol by the adrenals.
And more precisely, how can this management be personalized or tailored for patients?
Well, the first level, of course, of tailoring is to manage the patient according to its cause. So, for example, the most frequent situation is Cushing disease. Cushing disease means the pituitary cause of Cushing syndrome, so pituitary adenoma. So this adenoma can be removed by a neurosurgeon using a transfemoral approach, meaning in most of the cases today that the neurosurgeon will go through the nose to operate the pituitary lesion. When the cause is an adrenal lesion, and if it's a benign adrenal adenoma, usually it's on one of the two adrenal, and the endocrine surgeon can, by a laparoscopic approach, remove the adenoma. When the cause is a malignant tumor, which is hopefully a rare situation, but it can happen. When, for example, it's an adrenal cancer or a malignant neuroendocrine tumor, if this tumor cannot be removed by surgery, then you can use medical treatment for an adrenal tumor, or for an endocrine tumor, depending on the type of tumor, you might use a cytotoxic chemotherapy or a targeted treatment, as often in oncology. For a given cause, depending on the patient, you might also adapt your treatment. For instance, even though in most situations the first treatment is surgery, there are some patients that cannot be treated by surgery, at least initially, because, for example, the consequences of cortisol excess are so severe that from the cardiopulmonary point of view, it's difficult to operate this patient. Sometimes the tumor, even if it's a benign tumor, cannot be removed by the surgeon. So in this situation, then you will treat your patient first by drugs that will reduce cortisol secretion. Treatment can be also adapted to the project of the patient. For instance, Cushing disease is frequent in young females. And if the patient wants to be pregnant on the short term, when pituitary surgery fails, or if there is a recurrence after pituitary surgery of the Cushing disease, then in this situation, most of the medical treatment that you would use in another patient to control cortisol excess cannot be used safely during pregnancy. And in this specific situation, you might treat your patient by bilateral adrenalectomy, while in the other patient, you will use bilateral adrenalectomy only after failure of the other treatment. Then the other constraint to choose the treatment is also what's available in a given country. Not all the medical treatments, all the drugs, we are lucky enough now that there are many drugs available to treat Cushing. Not all of them are available everywhere internationally. And depending on the health system coverage, national health insurance or private insurance, not all the treatment will be reimbursed. So this might be also one factor that will have an impact on patient management.
And Professor Bertherat, beyond the Cushing syndrome itself, what are the most common comorbidities for these patients and how can they be managed?
So cortisol is quite a unique hormone that has an effect on almost all the tissues. So cortisol excess in Cushing syndrome can be responsible for many different complications. It can cause diabetes, it can cause hypertension, it can cause cardiovascular complication, osteoporosis, and osteoporosis can lead to bone fracture. Cushing syndrome can also cause depression and an increased rate of venous thrombosis. So not only you have to treat cortisol excess, but depending on what your patient has as complication of Cushing, you have also to treat with specific treatment diabetes or hypertension, depression, or thrombosis venosus.
And last but not least, Professor Bertherat, as many physicians can be involved in the follow-up of patients with Cushing syndromes, how do we coordinate their care?
So Cushing syndrome is rare and is also a complex disease. So the complexity means that you need different specialists, both for the diagnosis and for the treatment of Cushing syndrome. And because it's a rare disease, you need expertise. So you need to manage your patient for the diagnosis and to decide the therapeutic plan in a specialized center. So now, for instance, in Europe, with the European Reference Network, there are various healthcare providers that have been recognized as expert center for adrenal disorder. So the best, when it's possible, is to have an evaluation in this center. It's also possible through internet to discuss a case when such center is not available in your country through this European reference network. In this multidisciplinary setting, you need the endocrinologist, you need the radiologist, you need the hormonologist for the initial investigation. For discussion of the treatment, you need, depending on the situation, the neurosurgeon, the endocrine surgeon, in some cases, the radiotherapist. Depending on the complication, you need the diabetologist, the cardiologist, the psychiatrist, the specialist of blood coagulation disorders. So it's very important to have a discussion in these multidisciplinary teams. Then, of course, you need also close to the patient living in his geographic area, a specialist that could discuss with the spec center, and you need, of course, the general practitioner that knows all the different medical problems of the patient and that is very close to his home.
Well, thank you very much, Professor Bertherat, for all this clear information on Cushing syndrome. As for us, dear listeners, we thank you for your time, and we look forward to seeing you on our podcast channel for a future episode on Cushing syndrome. See you soon.